Hi everyone, my name is Dr. Leslie Zioke, and today we are going to provide an approach to irritable bowel syndrome for the NACOSCEs on behalf of Starmed medical education programs. Please note that this is not medical advice, so see your family physician if you have concerns that are similar to those addressed in this video. This video is for educational purposes only. So in the NACOSCEs, you have 11 minutes for each station and about 2 to 3 minutes to stand aside each station prior to commencing. In this time, you'd want to read the station prompts, take notes, make differentials, figure out which important red flags you would like to make sure you don't forget. And then you'd knock on the door, enter, you tell the examiner your exam number, make sure to sanitize your hands, introduce yourself to the patient, and you confirm the patient's identity. You then explain what you need to do and collect patient consent. Now, sometimes the questions are a bit vague or even misleading, and you cannot tell for sure what the problem is just from reading the question. For example, Sam is a 24-year-old male who has been waiting in the ER for a few hours on account of a recent bout of abdominal pain and change in bowel habits. Address his concerns. The question points to the fact that this is a young man in the ER complaining of abdominal pain. This can open us to a wide array of differentials, but most importantly, you have no idea whether this is a counseling question or a diagnostic question, and so you would have to find that out in real time. Now, because the major issue is abdominal pain, but the severity was not mentioned, nor do we know the reason why he was not immediately triaged as an urgent case in the ER. But we do know there was a change in bowel movements. We have to consider acute appendicitis, acute gastroenteritis, inflammatory bowel disease, acute diverticulitis, depending on age, celiac disease, and ectopic pregnancy. This is because we have to consider the possibility of the index patient being a trans male, but biological female. Depending on age also, you can have other differentials like abdominal angina. So, after introducing yourself to the patient, confirming his identity, establishing rapport, and receiving consent, you can then get into the history of presenting illness. Here, you'd want to ask open-ended questions like, what brings you to see us today? You don't interrupt the patient. Listen actively, but make sure you see whether they provide you the basic information that we need to get an idea of what his complaint is. The OCDF mnemonic, which is onset, cause, duration, and frequency, is a good start-off point, and you'd need to know whether the symptoms described are in keeping with irritable bowel syndrome. So usually IBS is insidious in onset, and so you'd be expecting him to say something similar. The course is usually intermittent, and for it to fit the criteria of irritable bowel syndrome, it needs to be 3 months or longer, and the abdominal pain needs to be at least once a week for the previous 3 months. And so now that we know that the major concern is abdominal pain, which in the case of IBS would be intermittent once a week for the previous 3 months, we would then want to explore the pain further, because you do not want to just assume it's IBS just like that. You'd have to find out what else is going on. And so you try to make sure that you know the PQRST AA mnemonic, which is the position, quality, radiation, severity, timing, and what are the aggravating and alleviating factors, and also the associated factors. Now, with IBS, the pain is usually non-specific, and they can tell you any type of quality of pain. So it could be cramping, it could be bloating, it can be a sharp pain. You just have no idea. There typically should not be radiation The pain should not radiate anywhere if it's IBS, and the severity would be subjective. So the patient can say it's 10/10 pain, but always make sure that you collect that information down. The timing for IBS, we usually expect it to be related to bowel movements, and then at this time you're also trying to rule out other differentials. So when you're asking for aggravating factors, you're thinking, hey, how do we rule out celiac disease? How do we rule out, as an example, lactose intolerance? And so you'd ask, oh, what aggravates it? You might have to use closed-ended questions to say, okay, how about milk? How about wheat? And you also want to know, in IBS, the trigger is usually stress. So you'd want to find out if there was any stress recently that contributed to his illness. You also want to know what alleviates it, and typically with IBS, it's alleviated by bowel movements. So those are things that if you're starting to think in that direction, you have to make sure that you are ruling them out while you are doing the HPI. When you get to associated symptoms, you would have to ask, because this sounds like a GI problem, you have to start asking, okay, so if the patient mentions diarrhea, you then have to do the COCA-B mnemonic, which is the color, odor, consistency, amount, and you rule out blood. These are very important to find out if there are any differentials that are more concerning. You find out about constipation, or if it's constant, or if it's alternating with diarrhea, which is what we expect in IBS. We expect it to alternate. If there are other symptoms like vomiting, it makes IBS less likely. You want to know about dyspepsia, which does some people with IBS complain of, but it also opens up to the possibility of, hey, is this acid reflux, is this a stomach, is this gastric ulcer or something else? After you're done with associated symptoms, it's always vital to discuss the constitutional symptoms. This is a very important point that we must never forget while we're doing any clerking. This is because you want to make sure there's nothing more sinister. If you do the NACOSCE and you miss out a red flag, that you are unlikely to do very well in that station. And so you always have to make sure you have found out about constitutional symptoms like fever, weight loss, night sweat, fatigue, anorexia, that sort of thing. And the presence of any one of them makes IBS less likely. And then we can move on to review of systems. This is what we use to further rule out or rule in our differentials. I like to start with psychiatry just so you don't forget it. So you'd find out about things like anxiety, stress, depression. These can be triggers for IBS, so you want to let the examiner know that you know that. You also want to check HEENT, find about things like blurred vision. Blurred vision occasionally can occur in IBS. Changes in hearing, all those sorts of things, you have to find that out. For respiratory and cardiovascular, you're really just trying to rule out the red flags. And things like palpitations, the heart racing, shortness of breath, that sort of thing, just so you don't miss a red flag and you show the examiner that you know what you're looking for. For genitourinary, you're trying to rule out pyelonephritis, nephrolithiasis, and UTI. These are all things that come with abdominal pain, and so you have to ask about flank pain, dysuria, hematuria, those sort of things. With musculoskeletal, you can just ask about pain anywhere else, lumps and bumps. Back pain and muscle occasion are quite common in IBS, so that's just something that you can put in your notes. For endocrine, you really want to rule out diabetes symptoms, because diabetes can come with abdominal pain, but you also want to rule out thyroid. You're trying to just show the examiner that you're a safe doctor that would not miss anything important. Hematological, immune, you're asking about things like if there's any bleeding, if there's anemia, if he has any food or seasonal allergies, which can then help point you towards the cause. For the skin, you're asking about any new rashes, that sort of thing. If they describe that dermatitis herpetiformis, then that is now ruling in celiac disease, because that dermatitis herpetiformis is like the pathognomonic of celiac disease. And then we move into medical history. You want to find out about past medical and surgical history. Has there been any recent instrumentations that has occurred in the patient? You want to find out about allergies, whether he's allergic to any medications and otherwise. You want to find out what medication the patient is on. Has he had antibiotics recently? Because that would start making you consider Clostridium difficile as one of the differentials. Hospitalizations, illnesses, and trauma recently. You also want to find out the family history, rule out inflammatory bowel disease in the family or cancer in the family. This would make you come up with decisions later on. Obstetrics and gynecology, depending on the gender. If it's female, you certainly want to find out the LMP, what kind of partners the patient has, how many partners the patient has had. If the patient has been on contraception, what he's taking. You also want to find out smoking, alcohol, and drugs, and whether the patient is under stress, whether the patient exercises, whether the patient has a diet. Obviously, so these are mnemonics, and some of them have already been addressed in the past, like allergy. So you'd be careful, because you're dealing with time, to make sure that you're not asking the same questions repeatedly, just following a mnemonic. The OSCEs come with different station formats. We have gone in depth as if that was a pure clerking station, but there are some stations that are both clerking and physical exam, and so you'd have to make sure that you are really managing your time to get as much within the history as possible, while you still have conserved enough time for the physical exam. If this is a station where you have physical exam and history, it means that your clerking will be 8 minutes, and the remaining 3 minutes you have to do a physical exam during that. And before you start the physical exam, you ensure you have found out if there's anything else the patient would like to inform you about. You'll make sure you thank the patient and then explain what you would like to do with the physical exam, and ask for consent. Make sure that you can be simultaneously washing your hands while you're doing that, but make sure that you wash your hands before commencing the physical exam. We would not address physical exam in this video, but there are other videos where you can see how we do an abdominal examination or otherwise. And once you're done with the physical exam, remember to thank the patient. So once you are done with your history taking or history and examination, you'd typically have to do the post-encounter. One of the common questions they'll ask you is, what are your differentials? So you have to list those out. They can also ask you what investigations you do. Obviously, you always have to do the baseline investigations, and the rest, the other investigations you do will be based on what you find in your history taking. If they ask you about what treatment you would give, you would have to just ensure that you let them know that there's no specific cure, but it can be managed. You reassure the patient. You always have to divide your treatment into non-pharmacological and pharmacological treatment. And so, under non-pharmacological, you can be talking about the stress management, exercise, avoiding the triggers. After identifying them, you talk about your dietary measures, like a regular meal schedule, increase fluid intake, so make sure that you're taking soluble fiber, and possibly a referral to a dietitian. Under pharmacological, it's really symptomatic treatment. So if the patient has spasms, you give antispasm medication. If the patient has constipation, you give laxative. If the patient has diarrhea, you give anti-diarrhea. And you also mentioned that if you found signs of stress, that some cases of IBS are put on low dose antidepressants. And so, thank you.